Hi everyone, we're going to wait just a minute or two for last minute joiners to the webinar, and then we will get started. Well, hello everyone. I'm Sarah Alsager, Managing Editor of the Soy Connection newsletter. Thank you so much for joining us today for our webinar to discuss the most recent issue of our newsletter, featuring information about FODMAPs and how soy fits in. Let's get started with a few housekeeping items. Our webinar today will be about 45 minutes in length. If you do have questions, feel free to type those in as we go, but we will reserve the question answer portion of the program for the end of the webinar. To ask questions, click on the Q&A icon at the bottom of your Zoom window. Another window will pop up and you can type in your question. A recording of today's webinar will be available after it's over and will be emailed to you. We invite you to chime in on Twitter or Instagram using the hashtag #SoyWebinar. And one more thing before we begin, we'd like to ask each of you to answer a couple of questions via our poll. So a couple of questions will pop up on your screen. Just launch the poll. There are 4 questions there. If you could just weigh in on each of those 4 questions, we would appreciate it. The first is, do you view soy and soy foods as a healthy nutritional choice? Number 2, how likely are you to recommend soy foods to your patients, clients, or others you advise? Number 3, how often do you use the low FODMAP diet in your clinical practice? And number 4, how would you rate your comfort level of understanding of the underlying FODMAP evidence, including its mechanisms, efficacy, and implementation steps? So we'll wait about 10 more seconds and allow time for you to weigh in on those 4 questions. Okay, I'm going to end this poll. Thanks to those of you who weighed in. Here's just a quick synopsis of where we stand with some of those questions. I know our presenter today is especially interested in seeing where our attendees stand on questions 3 and 4. So it looks like, as far as utilizing the low FODMAP diet in clinical practice, the highest answer there was less often than monthly at 36%. And our attendees today are somewhat comfortable in their understanding of the underlying evidence. So I think this is a great segue into starting our webinar today. All right. So thanks so much for that input. I'd now like to introduce our speaker, Dr. Jessica Biesiekierski. Jess is a senior lecturer, researcher, and registered nutritionist based at Discipline of Dietetics and Human Nutrition at La Trobe University in Melbourne, Australia. Thank you, Jess, for being with us today.
Hi everyone, a very big thank you to the amazing Soy Connection team, and especially Sarah for inviting me, having me, and getting me organised this beautiful Monday morning for me here in Melbourne. And a very big thank you to all of you for logging in today. I'm really excited to take you through the story and the evidence explaining all things FODMAPs. I have pitched it at those who know a little bit about FODMAPs, and we'll be focusing a lot about the evidence and the science. So hopefully this really means a lot of you can take some take-home messages from it. I'm going to start by setting the scene and just beginning quickly with starting at the beginning and defining the FODMAPs and what they actually are and their role in gastrointestinal symptoms, and move on to focusing on the evidence that actually supports the mechanisms of how we know FODMAPs behave, the data that supports the clinical efficacy of the low FODMAP diet, and then spend some time talking through the suggested steps for clinical implementation. It was interesting to see that sort of the majority of you are using it a little bit, but perhaps only monthly. So it'll be interesting to see whether that changes after this presentation. Lastly, I'm going to talk about how so many foods can actually still be included in the low FODMAP diet. So firstly, to set the scene of irritable bowel syndrome, this is a really common gastrointestinal disorder. It affects about 15% of the population globally, where patients experience abdominal pain and altered bowel habits. So they either predominantly a diarrhea or constipation, or a mixture of both as their key symptoms. We know that there's a really high frequency of perceived food intolerance in patients with IBS. And quite often, as you can see in the figure, so the last box plot on your right, you can see that the more severe the symptoms that the patients report, the higher the number of foods blamed. However, very few patients can accurately identify what those offending foods are correctly. And regardless of that, many will actually use dietary manipulation as a common self-management strategy. So as I go through the presentation today, one thing to firstly note is the challenges that can be associated with this self-diagnosis and self-management. So obviously nutritional adequacy, and then accurate diagnosis, investigation, and management. But also that food is really, really super complex. So this really makes it difficult for dietary research to be conducted, and I think is one of the reasons why progress in this area of low FODMAP diet and IBS and dietary intervention studies overall, the understanding of those has really just only come to full fruition. So the functional GI, or the functional gastrointestinal symptoms that define IBS, that pain, the bloating, the mixture of the altered bowel habits, or the diarrhea or constipation, they can also be found in other gastrointestinal diseases. But today we're just going to be focusing on IBS because that is where the large amount of evidence and data is. So those symptoms are largely related to the degree of luminal distension. This distension is made up of the luminal volume that consists of the solids, so the foods that we eat, gases, what we swallow or via fermentation, or fluids, so the number of osmotically active molecules in the lumen. Now, to identify potential dietary components that may be responsible, we can look at dietary carbohydrates because we know that they are poorly absorbed and therefore available for fermentation. And we also know that they're small in molecular size so that they can exert an osmotic activity. So therefore, meeting these criteria for potential targets and is what we group and focus on within the FODMAP acronym. So for those of you who don't know, although I think most of you do know, FODMAPs is an acronym that stands for fermentable oligosaccharides, so where we focus on the fructo-oligosaccharide or fructan group found in your wheat and rye, barley and onion and garlic, and the galacto-oligosaccharides, so the GOS, which are found in our legumes and our wonderful soy foods. Disaccharides, where we focus on the lactose, so found in dairy foods. I've also put lactulose there, although it's artificial. I think many of you will know of lactulose as that laxative that's often used in the hospital setting or even in the breath test setting. Monosaccharide, where we actually focus on fructose that is in excess of glucose, and that's due to the transport mechanism that I will briefly touch upon later on. And the foods that are high in excess fructose are largely your fruits, so your mango, apples, pears, honey, and the polyol. So we have two little polyol groups, the sorbitol and mannitol. Sorbitol is found in high amounts in your stone fruits, so a little picture of a peach there, and also found as an artificial sweetener. And depending where you're based and which chewing gum or a sweet brand you are consuming, you'll see that it can be added as a sweetener, an artificial sweetener into many of your chewing gums. So before I dive into the science, I just wanted to show this to highlight just how increasing the popularity of FODMAPs is. So this is a screenshot that I took from Google that shows the interest over time for people who have searched FODMAPs versus gluten-free in the USA. And you can see that it's really in the last 10 years that the FODMAPs in the blue line has really taken off. So I show you this really represents the popularity, particularly with the lay public and the Google users. Now we'll dive into the science, and I think that will then demonstrate, and you can see how it parallels with that timeline. So indeed, we have such a huge magnitude of evidence now for the mechanisms and clinical efficacy of the low FODMAP diet, that it's actually surpassed any other dietary intervention in the IBS space. The strength of research supporting specific FODMAP-induced gut symptoms has led to the low FODMAP diet actually being incorporated into many clinical guidelines, and particularly the international guidelines in the UK. So then they have the British Dietetic Association guidelines, and also the National Institute for Health and Clinical Excellence guidelines for IBS management in primary care in the UK. We know when we start looking into the mechanisms, evidence of mechanisms, that there are two key mechanisms, and I'll go through both of these in much more detail in the next couple of slides. But these two key mechanisms underlie the FODMAP effects. So the water delivery and the fermentation that you can see in the figure. So the little blue of the H2O and the big white clouds of the gas, increased gas fermentation. Additionally, there is, particularly in our IBS cohort, a really heightened visceral hypersensitivity. And this is the key reason why IBS patients versus a healthy person or a healthy control will experience those effects, those FODMAP effects, as symptoms. Before we go through some of the research in detail, I just want to highlight that FODMAPs do vary in their absorptive capacities. So fructose, lactose polyols, they actually have what we call partial absorption. So meaning they can either be reduced, slow, or fully malabsorbed. And this can depend whether there is lactase being expressed for lactose absorption, the activity of the GLUT2 or 4-5 transporters for the absorption of fructose. And it can also depend on the molecular size, the transit time of the gut, and other underlying or comorbidities and other GI diseases. For fructans and for GOS, so our galacto-oligosaccharides, we actually have no absorption, because we as humans do not actually produce the small intestinal hydrolases that are capable of breaking down those bonds within those polymer chains that are found in those fructans and GOS. This varied absorption, I just need to highlight, because this does then have implications for why we know there is individualized sensitivity to each of the FODMAP groups. So the first mechanism to go into a bit of detail is this increased small intestinal water delivery. So to understand this, there are a couple of key studies. The first one is this one from Barrett. And as I go through, and my references are down the bottom, you can keep your eye on what year the studies are published in, and you can sort of get a feel for why this FODMAP area is really quite new. So this, the Barrett study was 2010. So when the FODMAPs first started to become known in the scientific literature. So this study was a randomized, single-blind crossover feeding trial in only 10 patients who had an ileostomy, and they showed that their effluent water increased by 20% after a 4-day intake of a very high FODMAP diet compared with a low FODMAP diet. That total daytime output that reduced actually confirms the osmotic effect that we thought was happening with these FODMAP groups. And the figure on your right actually shows the perceived characteristics of the consistency as perceived by the patients of their own ileostomy output. And you can see that on the 4th day, again, from the high to the low FODMAP diet, there was reduced consistency. And so overall satisfaction with how they perceived their own ileostomy output. This second study, so building upon that first primary small intestinal mechanistic study, there was then this really elegant study from the UK that used MRI to measure small bowel water content, where the authors found a really pronounced, and that's quite clear from the bottom, from the C figure that you can see, an effect on the small intestinal water in response to acute challenges. So this one was just glucose versus mannitol. In this, they found that there was a 4-fold higher small intestinal water volume at that 60-minute mark after the consumption of mannitol compared with glucose, and glucose was used there because it's equimolar. And this study, the figure that I'm showing you actually is just in healthy individuals. The same magnitude of effect after that 60 minutes was actually seen after this study, which was also visualizing the small intestinal water. And they actually, in this one, if you focus on the fructose, so that B column, that B figure, you can see for fructose that there's clearly a lot of small intestinal water content there. And conversely, if you look over to the fructan figure, that the fructans had no effect on small intestinal water. And this is because fructose is an osmotically active monomer versus fructans. So fructans have a higher degree of polymerization. And this, alongside understanding the absorption plus understanding how each of the FODMAPs behave, actually help us when we get to the clinical implementation and understanding which FODMAPs are inducing which symptoms for our patients. So the second mechanism to focus on is the colonic gas production and the fermentation. So here again, there's a couple of really key studies. So first, again, you can see the 2010 date, and this was by Ong, and both the Ong and the Barrett studies were conducted by the Monash University FODMAP group. And you can see they sort of began and started this FODMAP story, and then there's been a lot more varied research globally that's gone on to expand and reproduce the understanding. So this study that you're looking at was another randomized single-blind crossover intervention study, and they used 15 IBS patients and 15 healthy controls. And they actually provided their participants with 2 days of either a low or high FODMAP meal plan and gave them all of the food. They measured breath hydrogen, which is what you're looking at here, and also abdominal symptom production. So the graph that you're looking at shows the production of hydrogen over the course of the 2nd day of each of those diets. And what you can see here is that the high FODMAP diet produced more hydrogen on average than the low FODMAP diet in both the IBS and healthy control groups over the course of the day. What you can also see by that solid line is that the healthies did also have a higher breath hydrogen production, but for the IBS, it was slightly higher. The second study also comes from, again, from the same UK group for using that MRI study protocol. So here they could also, using that MRI protocol, visualize the gas volume. So here the authors showed that inulin, so where they're using inulin as the fructan, caused a more sustained rise in the colonic gas, showing that it exerts its main effect in the colon, as you see here, rather than in the small bowel like you were seeing in the previous slide. So you can actually see here that the inulin challenge led to an approximate 2-fold greater colonic volume at about the 4-hour mark compared with glucose. And this was both in healthy individuals and in patients with IBS that they saw this pattern. So this tells us that fructans leads to a later and higher amount of total gas production, especially compared with fructose. And we saw that also when you compare it to the breath hydrogen results that they had in this study. So overall, this highlights the differences, again, in the degree of absorption and also in the gastrointestinal transit time of individual carbohydrates. So this is due to their differences in their molecular geometry. So the differences in that fructans, the longer chain, the other higher degree of polymerization versus the fructose and the mannitol that we saw on the previous slide. And this is why we see this variable availability for fermentation in the proximal colon. So why do only some people get symptoms from FODMAP? Sort of what's the differentiation between a healthy person and a person with IBS who's actually experiencing those effects as symptoms? We could see here, and what you see if you focus on the second and third blocks, you can see that the physiological effects are actually very similar between the patients and the volunteers. Whether it's following the intake of fructose or inulin, so the fructan. However, this study was really nice because it showed that although the physiological effects are very similar in both groups, it's only in the patients who more frequently report symptoms after fructans than in the controls. So this indicates that it's this colonic hypersensitivity to distension and really this visceral hypersensitivity that we talk about in the IBS group, rather than excessive gas production or excessive water content that actually produces these FODMAP-related symptoms in the IBS group. The last decade's popularity of FODMAPs is really paralleled by the increase in publication and numerous and various designed trials that have been assessing the efficacy of the low FODMAP diet in reducing IBS symptoms. Although the initial research was actually a little bit limited in its study design, and they may have used really quite high content of the FODMAPs to challenge with, for example, there's been a really recent surge, and you can see this again by the dates, and they give the publication date of the trials that I've listed, and they continue to be published. It's really resulted in these being better designed clinical trials and being able to show efficacy for the low FODMAP diet for IBS, and particularly in settings outside of Australia. So although those first few trials and the FODMAP term and the overall hypothesis was developed by the Monash University group, since then there's lots of research from around the world that's come out. The first meta-analysis that I've just put on the bottom there and asterisked for you all was showing that the low FODMAP diet and all of the randomized control trials using the low FODMAP diet reported a greater odds of reduction of abdominal pain, abdominal bloating, and overall gastrointestinal symptoms compared with healthy controls. So it's a really nice way to be quite clear that we've got a high level of evidence here supporting the low FODMAP diet. So I'm now going to take you through a couple of those key efficacy trials. Firstly, this one really remains the highest quality evidence for the low FODMAP diet's efficacy. It was a randomized, controlled, single-blind crossover trial where all of the food was provided as in a feeding trial sense. So its methods were really gold standard and an appropriate control diet was used, where although it was referred to as the low, you can see the typical Australian diet does have a higher FODMAP content in it, but at the same time isn't ridiculously high like some of the earlier trials that we're using. So this study used participants, or they gave participants 21 days of either a low FODMAP diet or that typical Australian, so a higher FODMAP diet, and then had a washout period, and then they crossed over to the alternate diet. Both symptom scores, and that's what you're seeing here, and stool collections were completed. I talk about the stool microbiota results in a couple of slides' time. And what you're looking at here, and you can see that the IBS patients had significantly lower overall symptoms on the low FODMAP diet compared to the high FODMAP diet. And no differences were seen in the gut symptoms in that healthy controls, which was important for us to see, because in some of our previous studies we had seen that the healthy controls were getting symptoms from the FODMAPs. So this really shows again that it was, you know, that normal load of FODMAPs is enough to trigger symptoms in an IBS cohort. Also, what was important here to note, if you focus on the A figure, is that symptom onset or resolution, so whether you're looking at the dotted line or the solid line, it happens within the first 7 days and then plateaus. So this is a really useful timeline to remember when it comes to implementation and educating your patients. Essentially, they will feel benefit, should feel benefit within that first 7 days of trialing the low FODMAP diet if they're able to do it in a more strict sense. The other thing to take home from this study was that their IBS patients that they used, so they did have 30, they actually made up all 4 subtypes of IBS. So we had a mixture of patients in here who were predominant constipation or diarrhea, or mixture of the two, or unsubtyped. And there was resolution and symptomatic improvement in all 4 subtypes. Other studies have further gone on to add to the clinical efficacy. So this study, which was conducted by the King's College group in London, and you'll see both Stordacker and Kevin Whelan's name a lot associated with some really high quality research that's come out of their group. So this study in particular, instead of actually supplying all of the food to participants, they used dietary advice as it would be used in clinical practice. And apologies, I don't have a nice figure to show here, but what you can see by the table, and you just focus and do a quick glance at the bold figures to indicate the significant values, you can see just how many symptoms here significantly improved after just that 4 weeks of following low FODMAP dietary advice. The next study I'd like to talk about is this Swedish study from Magnus Simrin's group. And here they assessed the low FODMAP diet with an active intervention. And what they used is the standard dietary advice that they use and that many centres use for IBS, following those NICE guidelines. It's important here to acknowledge, and what I've put in red is that the NICE guidelines do also limit some of the most common FODMAP groups. So you can see the onion and garlic, and also other known sort of gut stimulants like your caffeine and alcohol and spicy foods. So what you can see in their main results, and this is looking at the IBS symptom severity score, you can see that there was significant improvement and clinical response in both arms. So both the low FODMAP diet and that standard dietary advice, or the NICE guidelines, but there wasn't actually any difference between the two. So I suppose when we come to analysing this actually still gives us information about the low FODMAP diet's efficacy, but it perhaps also gives us a take-home message here that it may not be the right approach for every single IBS patient. And again, understanding the best dietary intervention for the individual. This next study that I'd like to show you is from an American group that also assessed efficacy based on dietary advice given to IBS patients to follow for 4 weeks. And you can see from the left figures in my yellow highlight that there were more patients who reported adequate relief of gastrointestinal symptoms, and more who responded to pain following the low FODMAP diet. So again, similar to the previous study, you can see that there was symptomatic relief felt on both arms. However, it was a little bit stronger on the low FODMAP diet. So many of those studies used a 2, a 3, or a 4-week intervention period. We know that patients are staying on the low FODMAP diet for much longer. And so we often get asked, what about long-term efficacy? I know that there is at least 2 retrospective follow-up studies, and there's more being done in this space, especially now as we can revisit some of those older studies, and we can also revisit now some of our patients who we've had in clinical practice for much longer. So this the first text results that I'm showing you are from Shepherd, and you can see again from the date of 2006, so one of the very first FODMAP studies to come out. That she showed, and she did this by making a phone call to her patients about 14 to 16 months after they had commenced the low FODMAP diet with her in her dietetic practice. And she showed that more than half were still reporting satisfactory symptom relief compared to what their baseline or habitual diet was. This second study by Harvey that's shown in the figures here shows that at the 6-month follow-up, so if you perhaps focus on the right figure, the change in IBS symptoms where the red circle is, you can see there at the 6-month follow-up, the patient still reported, and you look at the mean value there in the middle, still reported a reduced IBS symptom severity score compared to their baseline. So if you compare that red circle compared to the first, where it's significant between the A and the B, so where those circles, the block circles are, and that, you know, at 6 months, although some patients have obviously had some symptoms return, they're still following a moderate FODMAP diet, and they are still reporting symptom improvement. So we know that patients continue to follow the low FODMAP diet and continue to experience symptomatic relief. The next question is, how adherent are they, or how strict are patients in their FODMAP diet in the long term? And this is really important for us to know, of course, as nutritionists and dietitians, to understand you know, how restrictive they are being in their dietary intake. So this study asked patients about how much they were consuming FODMAPs at long-term follow-up, and they found that patients weren't following a strict low FODMAP diet per se, and instead they were following what they termed an adaptive FODMAP diet. So where you can see in the yellow highlights that I've added, that fructans in particular, and also the excess fructose, were the 2 main FODMAP groups that their patients reported as, or considered, their most key FODMAP triggers in their longer term maintenance of symptom control. This study also found that over half of the patients reported long-term symptomatic relief on this adapted FODMAP diet. They also looked at nutritional adequacy and acceptability of the diet as well, and found positive evidence for those 2 points. So speaking of nutritional adequacy and moving into the potential hazards of the low FODMAP diet, where we know that following the low FODMAP diet will result in at least 50% reduction in fructan and GOS intake. Knowing that these are your key natural prebiotic fibers and important for stimulating the growth of beneficial gut microbiota, it makes sense that we need to caution and understand these consequences for gut health. So here I've listed in the table the increasing number of studies that are exploring the impact of low FODMAP diet on microbiota, and what you can see is that there's different study designs and there's lots of different types of analysis techniques. Important to note when we start comparing the results. I will fly through these results a little bit more quickly. The first study results I would like to show come from, again, that King's College group in London, where they had 2 different studies that both found reduction in bifidobacteria concentration, proportion, and abundance. The Helmos study from Monash University that I showed you in the symptom data from, they also did a microbiome analysis and found unfavorable effects in fecal pH, Clostridium and Ruminococcus. And since then, there's been also a number of other studies. I just wanted to highlight the Macintosh one because they actually showed that low FODMAP diet is associated with alterations in the metabolome. So they used an urine metabolomic profile. And you can see there that there's a separation and a clear difference between the patients on a low FODMAP diet compared to the patients on a high FODMAP diet. So despite obvious changes in the microbiota being found in these short-term studies, I need to stress that we don't know what this actually means yet for any downstream effects and what are any related health outcomes. So it does highlight the importance of re-challenging and reintroducing the FODMAPs and avoiding that long-term FODMAP elimination until we know more about what these microbiota changes actually mean for our patients. The low FODMAP diet, when delivered by a specialist dietitian, can be of a high dietary diversity, remembering that in a low FODMAP diet, that it never actually excludes one food group. Some studies have assessed nutritional adequacy in more detail and have highlighted that there is lower energy, calcium and fibre intakes, so focusing on the little yellow highlight block. And we know that, of course, there's changes in nutritional intake with any dietary intervention, but particularly with the low FODMAP diet, we need to be careful with the adequate calcium, so encouraging consumption of lactose-free options, for example, and fibre, and ensuring grains and cereal alternatives are consumed still that are from the low FODMAP list. Moving quickly into the protocol for implementation of the low FODMAP diet, this should follow a three-phase approach. So firstly, elimination, where there's total FODMAP restriction for 2 to 6 weeks. Second, re-challenge phase, where we assess the tolerance. And if it's efficacious, then we start re-challenging and loosening the diet according to tolerance. If it's adherent, then if adherent and there's actually been no response, then obviously abandon the diet and move on to the next management approach. Long-term maintenance, where we focus on this personalisation as needed for symptom management for the individual. Looking at phase 1, this diet really we know should be implemented in symptomatic patients only and should be led by a trained gut expert or experienced dietitian who has those mechanistic understandings and understanding of the FODMAP principles. When the dietitians are educating the patient on the low FODMAP diet, we know that they need to explain and interpret the comprehensive food lists and provide tips for how patients can switch their high with low FODMAP foods rather than just eliminating FODMAPs altogether. There's lots of tips that we can use to help encourage our patients to still follow a nutritionally adequate diet and what they can do to switch in their normal dietary intake. So tips include double soaking of legumes, and this is because FODMAPs are water soluble, so the GOS, those galacto-oligosaccharides will actually leach out into the soaking liquids, or using a garlic infused oil, and that's because fats are fat insoluble, so only the flavonoids will actually leach out and the fructans will stay within the garlic clove. There's also been a couple of really great studies to highlight the use of enzymes. Of course, the use of lactase is really well known, and I just wanted to quickly put this study up to show that taking an oral alpha-galactosidase, which is what they used in this study, with high GOS foods, and this is important to note when we start talking about soy food intake within the low FODMAP diet, provides a clinically significant reduction in symptoms in those individuals who were sensitive to GOS. So it might be a really nice way to improve tolerance and use it as adjunct therapy to the low FODMAP diet. The second phase focuses on re-challenge and reintroduction, and this can often be the most time-consuming phase of the low FODMAP diet. This paper is a great paper to go through tips and provide a resource for the recommended approach. We recommend that you challenge only one food at a time, and it's really important to do that to establish that individual tolerance per FODMAP group, knowing that that will vary among patients. And you need to be careful in what foods you are choosing, that food only contains one FODMAP. Normally there will be one challenge, so one FODMAP group, either say fructose or lactose, over 3 days, starting with whichever food group that the patient misses the most, and then increasing their dose to assess their individual symptom severity. Long-term dietary restriction of any kind, especially low FODMAP diet, is not encouraged, and both reintroduction and liberalisation of the diet should continue while maintaining symptom control. It may also be helpful when educating your patients to highlight that reintroduction of FODMAPs may actually attenuate or improve some of the microbiota changes that we're seeing. So this figure and this study from Norway supports this, where you can see the changes from baseline to low FODMAP diet, and then with the reintroduction of FOS, so fructans, which they actually used as a supplementation in this study, that the bifidobacteria and actinobacteria groups actually recovered, and with that FOS supplementation actually recovered beyond those baseline levels. So this really highlights and gives promise for the recovery of our wonderful gut microbiota. I talk a lot about food lists, and people often ask for updated food lists, and you really can't go past using the Monash University app and database. It's the most detailed, it has ongoing and is regularly updated. Just this week, actually, I got a notification that more American and some Mexican foods were added. And it's really, important that the food lists that we're using are scientifically valid and are correct. So that the database that Monash have set up using this scientific measurement and establishing a global database to really broaden the food composition database of FODMAP understanding outside of just Australian products. And this is really important because we know that FODMAP contents can vary for lots of different reasons: varieties, climates, seasons, brands, the ripeness of foods, and cooking methods, for example. And full note, I am not associated with Monash anymore, and the signing up to this does cost a small amount, but it does go back into supporting more of their FODMAP research, and especially more FODMAP food analyses. So lastly, and really probably most important given the platform for why we're all here today, is to highlight the role of soy foods within the low FODMAP diet. And Kate Scarlatta wrote a fantastic article in the current newsletter that highlighted just how many soy foods can be suitable and still consumed within the low FODMAP diet. So we do know that soybeans contain GOS, the galacto-oligosaccharides, and soy products will contain some fructans. But these foods will vary in their content. So that's where understanding the composition is really important, particularly for those who follow a vegetarian diet where they rely more heavily on that soybean and legume intake for their protein content. My green highlights here show the foods that have been tested as low in FODMAP content by the Monash testing lab. And you can see here that really it depends on food processing, fermentation, and maturity of the plant that impacts on the FODMAP content. So edamame, for example, has less FODMAPs than the more mature soybean. There's differences in tofu and tempeh, and these are likely to be due to the liquid content and fermentation processes. Products that utilize protein versus the whole soybean will be lower in FODMAPs due to the processing and removing or breaking down of that carbohydrate content and leaving only the protein component. Remember that FODMAPs are water-soluble carbohydrates, so draining of the liquid from canned beans will reduce the FODMAPs, and there's some really nice studies to support that. Also remember that consuming the galactosidase enzyme supplement that I showed a few slides ago from the Tuck paper with soybeans may also be a great way to mitigate those IBS symptom induction and ensure that our patients can really enjoy their soy intake while still following a reduced FODMAP diet. So lastly, just to quickly summarise, hopefully I've been able to summarise the convincing clinical evidence and mechanistic understanding for the low FODMAP diet in IBS. It should really only be used in symptomatic patients and be implemented by a trained dietitian who understands those food lists and enables individual tolerance levels to be established. Although we know that there are microbiota changes that happen, it is likely they are able to recover, but regardless, we still don't want to encourage long-term dietary restriction. There are a number of remaining gaps, and perhaps we can talk, some questions will come up about these, and I know that there are many studies and research groups looking into these. I've listed a couple of authors there for you, so looking at the FODMAPs in other clinical groups, working out how we can actually identify who will best respond and most likely respond to the low FODMAP diet. And then again, looking at that long-term manipulation and what else we can do to encourage our patients to increase and return to their FODMAP, being able to consume FODMAPs comfortably. Thank you all very much for listening, and apologies for going a couple of minutes over time.
No worries. Thank you so much, Jess, for that review of the literature and the tips for implementation. We want to transition right into some questions. So here we go. Number one, Jess, the first question that's come in, is there any evidence for a suggested approach for using the low FODMAP diet in children?
A great question, because all of those studies that I did show were in the adult population, and we do know that IBS is increasingly common in children. The prevalent statistics vary a bit, but there are some stats numbers that are up around the 20%. There is some evidence that is really coming out looking at the low FODMAP diet and how to implement it into the pediatric population. So there's actually a randomized control trial that used school-aged children. And this was Chupazzi Bruno from the Texas group showed in Houston, showed that a reduced severity and number of abdominal pain episodes, as well as a reduction in gastrointestinal score, was actually observed after 2 days of the low FODMAP diet intervention. And they compared that with the typical American childhood diet. So I think there is evidence there to support that low FODMAP diet may be efficacious in children, but we do need to caution how we go about that consultation, ensure that a specialized pediatric dietitian and perhaps a gastroenterologist is also on board. You know, we have to caution the use of restricted diets in growing children, and then understanding that implementation. So when we look at the implementation serving sizes that I showed on that implementation slide, that perhaps you would halve or even quarter those challenge sizes for when it comes to understanding their individual tolerance levels.
Okay, thank you. All right, next question is, what enzyme supplements do you recommend?
Great question. So if you go to the top, so I obviously am a researcher and I'm based on the science and the scientific literature. My go-to would be that the TUC paper that I referenced when I talked about the GOS enzyme. And in that study, I think they used the supplement called Beano. I do know that there are others on the market, and I would encourage you to, you know, try them out with your patients. They're not going to do them any harm. And if it helps them increase their legume and soybean intake, then that's great. And the only thing would be to watch for is just making sure that that ingredient of the product is indeed only that galactosidase enzyme.
Okay, good. All right, the next question is, when doing the food challenge, if they tolerate one of the foods listed, is that a good indicator that they will tolerate other foods in that classification?
Yeah. So this is where it comes really important to understand that food composition database. So you don't want to challenge with apple or watermelon, for example, because those foods or fruits both contain a number of different FODMAP groups. So you want to choose a challenge such as mango or honey that only contains excess fructose. Whereas if you use apple, for example, that also contains two other types of, it also contains sorbitol and fructane. So you want to challenge with something that's pure in its and only contains one FODMAP group, and that then gives you insight that that FODMAP group, so excess fructose in this example, that patient will be able to tolerate and absorb excess fructose. Then when you start introducing and re-challenging with other foods, it's important to note and educate the patient that when you then start consuming whole meals, that it's then very difficult to be able to control that meal only contains that one FODMAP. So the answer is yes. I expanded a little bit there.
No, that's great. That's good. Okay, well, I think we'll take 2 more questions and then we'll wrap up. The next one is it advisable to give FODMAP diet to pregnant women?
Oh, great question. And did I have it on my final slide? If not, I will refer you to go to a paper that talks about using the low FODMAP diet, and the first author is Marina Ikanovou, a Greek name, but again from the Monash group. So if you just search Peter Gibson or Jane Muir, it should come up. And they provided the low FODMAP diet to breastfeeding women, and in one of their review papers that followed on from that, they talked about the safety of providing it to pregnant women as well, particularly women who have ongoing IBS or have sudden onset of some type of gastrointestinal symptom. So it is safe, yes, and definitely within the breastfeeding space, it shows efficacy for being able to improve not only the mum's gut symptoms, but also if you have an infant with colic symptoms as well.
Wonderful. Okay, I think we'll take one more question. There are so many coming in. So Jess, we may try to coordinate with you afterward to answer some of these offline. So thanks to all of you who have submitted questions. All right, here's our last question. Do you recommend waiting a certain amount of time before re-challenging a FODMAP/food that a patient did not tolerate during phase 2?
Yeah, I do. And this is why that re-challenge phase will take so long. And particularly if it's sort of disheartened the patient a bit as well. You want to make sure that you've got them feeling confident and comfortable to re-challenge. And you obviously want to make sure that their symptoms have reduced back down to baseline of that resolution, so that's symptomatic base, symptom free whilst following that strict low FODMAP diet before going on to that next challenge, and perhaps choosing a challenge and starting off with a smaller amount or a food that they really miss or something to get back up their confidence, because it is a concern that many patients are following a low FODMAP diet long term and not returning back to us, particularly here in Australia. You sort of see them for the initial consult, teach them a low FODMAP diet, they feel great, and they don't often return for all of those re-challenge follow-ups and review consults. And we know it's because they're reporting that they're feeling better and they feel comfortable. They don't want to risk having their symptoms increase again. So it's really based on that individual, when they feel comfortable to re-challenge again. And if they don't make it through that challenge, we also recommend that we encourage the patients to re-challenge in another 6 months' time, and to try and sort of always push and build that tolerance level to each of the FODMAP groups.
Excellent. Well, thank you so much, Jess. I think that our audience has been engaged the entire time, and we appreciate you sharing your expertise today. If what you heard today, sorry, Jess. Yes, thank you so much. If what you heard today was beneficial to you, I invite everyone to connect with Soy Connection online on Facebook, Instagram, and Twitter. We regularly share resources such as the newsletter and information like what you heard today, recipes and tips about soy foods, and lots of other information about this high quality plant protein. And in addition to today's webinar, we have hosted webinars on soy's role in a plant-based diet, on fertility and healthy aging. So if those areas are of interest to you, the recordings of those webinars are available at soyconnection.com. Immediately following our webinar today, a window will pop up with a survey about today's event, and we would strongly encourage you to complete this quick 3-minute survey so we can continue to provide you with worthwhile and relevant content. And that concludes today's webinar. Thank you again for joining us. Take care, everyone.